My name is Andre Maksimow, and I'm with Kaufman Hall. Really excited to be here today with you all right now and talk about some of the 5 healthcare trends that we are about to present to you here. So for me, it's particularly interesting and exciting because in the 2000s, I spent a lot of time in senior living. So I was headlong in senior living, CCRCs, and kind of focused in that segment of the business. And then since about 2010, I've been primarily focused on hospitals and health systems. And for the last 10 years, it's always been the two worlds were always separate, they never crossed. But now they're starting to become a lot more momentum right now where those two worlds are now starting to combine in a much more meaningful way that I think makes this really exciting. So really look forward to getting to know all of you a little bit further and talk about some collaboration opportunities. So today's format, if you will, what we're gonna do is, so I'm gonna talk for about 35, 40 minutes, just kind of set the tone a little bit, describe the 5 healthcare trends, give you some background information, and then going to ask our panelists to come up here as well. So then we're going to have a bit of a free-form kind of dialogue, ask some Q&A. And then what I'd like the audience to do then is, after we go through it, I think there's going to be microphones on this side and that side. So please feel free to interject and ask some questions. We'd love to make this as interactive as possible. So the 5 trends that we're going to go over today. These are the ones that are listed, and the way we kind of view this is, from Kaufman Hall's perspective, is that the primary trend that's really causing all these changes that are going on right now is that, put quite simply, healthcare is just too expensive here in the United States, just simply put. And the growth trend has been unsustainable. There's been a lot of pressure on the government, employers, all the while, and this trend really can't continue, or at least that's what we thought 10 years ago, but it still has. But anyway, that's the overarching kind of trend that really is driving a lot of the changes. And then perhaps these other trends are more kind of result from that overarching trend, which is the emergence of the healthcare consumer. You never quite, at least I never thought I'd hear healthcare and patients and customer satisfaction or consumer in the same sentence, but now that's becoming a lot more common. We'll talk a little bit about that. Some major changes in healthcare delivery. So I think the traditional way of thinking about healthcare delivery was you have your community hospital, you have your doctors and physicians, and that's always the way things were done. And it wasn't really accessible, wasn't quite convenient, but for whatever reason, we all tolerated it and we continued on. But now things are definitely changing in that regard, and there's some pressures that we're gonna talk about in a little bit further detail. And then finally, we're gonna wrap it up with some potential disruptors, give you some ideas. Some of it might be a little provocative, may or may not be, just give you some food for thought. And then finally, we're gonna wrap it up with why scale matters. So in senior living, I know that there's a lot of transactions that go on, 300 to 400 per year. In health systems, there's a lot of transactions that are going on as well. But what you're seeing is larger and larger deals because quite frankly, the smaller players really just can't survive right now. And there's a lot of forces at work there that we're gonna get into a little bit more detail. So that's the agenda, and let's go ahead and jump right into it. So this is probably a graph you've seen quite often. All right, the cost of healthcare, how it's growing, et cetera. I think one stat that always kind of resonates with me is that, number one, so since 1970, if you look at a 50-year look, healthcare inflation has been about twice the overall inflation rate. And that's what's kind of led up to this going from 7 to almost 18%. So systematically each year, healthcare inflation's going up by 2 times inflation or something more than that. And what that's doing obviously is as each year goes by, that's crowding out more and more discretionary income, more and more tax dollars, more and more things that could otherwise be used for other uses. And a common question we field is, well, being in the healthcare business and focusing a lot of our not-for-profit health systems, sometimes the question's raised, well, what's so bad about this, frankly? Healthcare is a generator of jobs. The economy's, it's a big part of the economy. Why not continue this on? I think the major factor, I think everyone pretty much agrees upon, is that it's just in essence a tax on the system, a tax on our economy. It crowds out investments and other things that are worthwhile. And quite candidly, US healthcare, if you look at it from a broad spectrum, it's not great. We're probably one of the highest costs, and we have some of the poorest outcomes overall in terms of life expectancy and healthcare outcomes. So we don't do a great job of it. And the questions then become, all right, well, why is it so? We'll get into a little bit more detail here, but Largely the reasons for that is, number one, U.S. healthcare, we probably have the highest prices in the world, put simply. That's one of the major drivers there. And then the other two drivers, which perhaps are getting a lot more attention now, is that, in essence, we really have a sick care system, for lack of a better word. What I mean by that is, historically, the focus has always been on treat, surgery, treat. So something's wrong with you, go in, get something treated. It's never been focused more holistic on care management. So for example, 80% I think of folks over 65 have chronic disease. There's not been the incentives from a reimbursed perspective or otherwise to actually treat those folks more holistically and treat their chronic conditions, which ultimately will lead to more downstream type events. And that's not occurred. So, in general, U.S. healthcare, a lot of problems. That's kind of the macro view. Moving on, consumer share. Just looking at this from a consumer perspective. So here are the key takeaways from this slide. So number one, healthcare costs going up. We've talked about that. On the employer side, in general, what's happening for consumers are that, number one, it's going up, but the interesting thing is it's going up for the employees themselves. So give or take from 2008, 26%, now you're taking the 28%. The other aspect of this, which is pretty important here, is that deductibles are going up here as well. So in essence, you're paying more for less insurance. You have more of a deductible. And the reason for that is, by and large, employers right now are deciding, well, it makes a lot more sense for us to kind of put out a high deductible health plan. It's going to be cheaper. And hopefully our employees are a little bit more prudent with their healthcare dollars. Now they're actually putting the healthcare dollars out, a little bit more sensitive to it. Perhaps there's more, perhaps at least the idea is that be more judicious with your healthcare dollars and you'll do some more shopping. So I think that kind of brings us out to the first polling question here, just to get a sense of the room. Oh, okay, so we have it right now. So this audience at least is a little bit below where we see nationwide trends for whatever particular reason. We talked about it just before, it's about 45, 50%. But in general, what we're seeing is that the prevalence of high deductible plans is probably not abating. And that's a major reason why we're going to get into the next segment of why consumerism is really becoming more of a focus. So consumerism, the simple way to think about it is, from a consumer standpoint, the things that really matter are, number one, access. When can you get the care? How can you get the care? When do you need the care? The experience, again, like I mentioned before, traditionally healthcare, the notion of customer experience or kind of the focus there has never really been non-existent. Now, I think with the push with millennials, they have everything on demand, when they want it, how they want it. They're the largest age cohort right now, so what health systems are doing now, they're really making some fundamental changes to the way they're operating. And then lastly is the cost equation, which is probably, again, the theme that runs through many of these slides right now. Things are just too costly, and what's going on right now in the industry is there's definitely more of a push toward price transparency. Now, there's obvious constituents that are opposed to this for various reasons, but nonetheless, not the easiest thing to do to figure out exactly, what your hospital charges for one procedure versus the other and go shopping. So we'll talk about that a little bit further. So at Kaufman Hall, we do a survey each year, and we survey healthcare executives, and we also survey some healthcare consumers. And we try to keep our finger on the pulse of what's happening right now in terms of, what are the trends right now in terms of access and convenience and, the ability to kind of get your healthcare in more innovative ways. So to kind of run through this briefly, virtual care, that's the likes of MD Live. You guys might have heard of that. So being able to actually access a physician through your computer on demand, it's about 25% of our consumers say that they strongly agree that that's available. In terms of being able to schedule an appointment during nights and weekends, that's about 40%. And having overall access to get care without a scheduled appointment, that's becoming a lot more prominent too. And probably the best example of that is, I don't know if you guys are familiar, but some of the urgent care locations that are popping up right now and more of the retail locations. You get the healthcare when you want it. And then finally, the ability to schedule visits online. This might be a bit of a misnomer here in terms of 49%. This is largely just for patients that are existing patients of a health system. So I guess the takeaway here is, from our perspective, things aren't really quite where they should be, but they certainly are getting better. This is perhaps one of the more interesting slides here in the deck. And just to give you some background, so I work with a fair amount of different health systems, predominantly in mergers and acquisitions. And some of this data was passed along to me from a CEO of about a $1.5 billion health system we talked about a little bit. So here, just to kind of ground you, here's where the data came from. So a bunch of self-insured employers came together and said, let's do a study and try to probe and figure out what's exactly the pricing differences by hospital, but then also by geography here too, across America. And here's kind of the key takeaways here. For those states that can get a pretty good data set, it was about, I think it was something in the range of $13 billion worth of healthcare spend, about 4 million enrollees. And what they focused on entirely was just hospitals. Because from their vantage point, they felt that hospitals comprise about 50% of the spend. That's what they should focus their efforts on. So the takeaways here, I think, are for those folks that perhaps live in Indiana, not great news for you. You have the highest cost healthcare overall in terms of inpatient and outpatient care. And for those that might live in Michigan, you actually have, at least from the prices of the providers, the hospitals, they actually charge the lowest. And there's all kinds of different reasons why some of those dynamics might be going on. But I think the key takeaway here, though, is, and to explain this just a little bit further, what these percentages represent is what the study tried to do is calibrate the costs to Medicare. So they tried to take a common denominator and take it all down to Medicare. So there'd be easy comparison points and benchmarks going across all the hospitals. So this is where the results came in. So it varied with inpatient and outpatient between 150 to 300% of Medicare. The chart on the right, I think, is a little bit more interesting here because what this really shows is, we talked about inpatient, outpatient, but now just focusing on outpatient, this is where you have some significant diversity in terms of pricing. The variation is just absolutely incredible what this study found. I know you can't see this on the screen. We'll go to the next slide, but basically what you have here is along the bottom are the states that were studied in order of increasing cost. So the cheapest, again, was Michigan, the most expensive, Indiana. We're going to focus on Colorado just for a minute here, but to key in on Colorado, you have a pretty good data set of claims that they looked at. And what you really see, here's the headline that came away from it, is hospitals in that region, at least for outpatient charges, they range for between 100% and 800% of Medicare. So to boil that all down, for procedures like imaging, lab tests, whatever you might get at the hospital, it could be 8 times as expensive in one hospital versus another in Colorado. So that's where you're seeing a lot of that variation. That's some of the underpinnings right now, some of the key drivers right now where folks and disruptors and others are trying to get to and saying, these differences in prices really don't equate to quality, so how can we get at this to perhaps save some additional dollars? So the next question here from a polling perspective is, the question is, now that you heard some of this data, maybe some of your practices before, but would you actually go out and research the cost and or quality of care before you got care for some low acuity type services? Would you actually do that? Or in fact, would you just take usually the physician referral and the recommendation rather than doing that? So maybe a quick, wow, okay. Wow, so the results are bouncing around, but looks like it's settled in at 33%. 40, wow, even further. So let's call it 40 here for argument's sake. That's probably generally what we're seeing around the country right now too, is in terms of folks actually going out and research. I'm not gonna get into a big discussion about this, but the one thing I would take away, what you could take away from this conversation is, before you just accept the referral, if it is a procedure, you have a high deductible plan, call up the hospital or call up the provider and ask, what is the cost of this particular procedure? They will generally give you the answer to that. And now they can't tell you exactly what your out-of-pocket will be otherwise, but they can give you the headline cost of the procedure. And I think at least from our perspective, that's a long way from where things went. Because 4 or 5 years ago, if you actually asked the hospital, what do you charge for that procedure? They would shrug their shoulders and say, I don't know. We'll tell you in about 6 weeks when we give you the bill. That was the answer. So anyway, I thought this was an interesting takeaway here for this group. So we talked about the consumerism, changes are going on, the overarching cost increases. Now in terms of healthcare access and delivery, what's really driving those changes? Not to belabor a lot of these points, but traditional healthcare delivery is being pressured by a lot of different data points. We just talked about consumer expectations. Folks are looking for things more on demand, more when they want it, how they want it. Health plans and employers are at wit's end right now in terms of healthcare costs. By and large, this very favorable economy has probably mitigated some of their efforts. Folks have, the employers have not wanted to disrupt any of the health plans for fear that they can't recruit the right employees. But if the economy does ebb, you're going to see more of the employers getting a little bit more forceful. And then finally, the government, whether you like the administration or not, the current administration in force right now, they're really having a big push right now in terms of price transparency. So one of the things that are up for grabs right now is that hospitals would be required to put out pricing, not what they charge necessarily, the gross charges, but actually what they get paid from insurance. So right now, this is in litigation. As you could probably guess, the hospital lobby, the American Hospital Association, isn't really in favor of this rule right now, so that's going back and forth. But from our vantage point, we think that a lot of these differentials aren't sustainable. And then finally are some healthcare disruptors that we'll discuss. So in terms of healthcare delivery, just to explain this a little bit further, maybe it's not conventional wisdom, but in general, inpatient or entering into the hospital, that utilization is going down significantly, has been going down for the last 10 years. So for most hospitals right now, they're quite hurting right now that more and more people don't need the inpatient services. So you don't need to be checked into a hospital. You can actually get a lot of the services done on an outpatient basis. And the best data we could find is Medicare to illustrate this point. And what you see on a per capita basis, at least over the last 10 years, is the amount of outpatient visits have gone up 43%, and inpatient has gone down by about 20%. And the takeaway here is, for those that are trying to track hospitals and try to understand the business a little bit further, in general, across the country, with the exception of some of the Sun Belt states, inpatient admissions, a major driver of their profitability, is all going down right now. And they're switching over to outpatient, but nonetheless, inpatient's definitely taking a ride down. And for this particular group, we thought it might be interesting to take a look at home health utilization versus skilled nursing. Are a lot of those trends true here too? So is care going to the lower cost setting? This is the first time we looked at this data. I expected there to be similar trends, and there are. We had to do a little bit more math here to figure out what these trends were, but in general, from the last 10 years, taking those same data points, what you see is skilled nursing on a per capita basis has gone down about 16%, and what you've seen is home health episodes on a per capita basis have gone up by about 10. We've kind of tried to get rid of some of the noise in terms of the fraud that goes on in home health, trying to remove those states that perhaps have suffered some of the most fraud, Florida, Illinois, Michigan, and Texas, and that bumps it up to 10. So needless to say, whether you talk about hospitals or you talk about skilled nursing and home health, care is definitely going to lower cost settings, more convenient lower cost settings, and that's what's happening. So now that we've discussed some of the care delivery and some of the other forces that are looming, here are two companies that, frankly, a lot of healthcare executives are staying up worrying about a little bit at night, is United Healthcare and their Optum division, and then also CVS Aetna. So United Healthcare is obviously a household name, but Optum may not be. So what Optum is it's a separate business, separate subsidiary from United Healthcare. And what they do is their kind of mission, if you will, is to provide data analytics. They provide information to payers, other payers, and also health systems. But the other thing that they're doing right now is your insurance company is basically getting into the provider business. So they're going out there right now and buying up a lot of providers. So they've gone on a systematic acquisition spree for the last 3-4 years, and they purchased a significant amount of physicians. They purchased ambulatory surgery sites. They purchased urgent care, and they also even purchased a healthcare consultancy called the Advisory Board. And their simple strategy is, looking at it this way, is that they want to be in the top 75 markets by population, and they want to control the front door from a physician standpoint and redirect care to anywhere but the hospital from a cost perspective. And that's the grand strategy from Optum and United Healthcare. CVS Health, so they've recently kind of made some major shifts in their strategy. What really prompted this was the fact that they bought Aetna. So now you have the reimbursement side of the equation covered, and there's all the incentive in the world right now for CVS to start thinking about, hey, maybe we should get in this provider business right now. Traditional healthcare is probably not serving the needs that are needed out there. Let's get into this business because, quite frankly, There's about 11,000 locations nationwide. They got a huge footprint right now. And I don't know what the exact stat is, but I think something of 80% or so of the population lives within a 5-mile distance of any one particular CVS. So they have all that infrastructure out there right now. And what they're deciding to do is, you guys are probably familiar with minute clinics. You've seen that. You might have used them from time to time. Minute clinics are largely just a nurse practitioner. They really don't do much aside from prescribe antibiotics, maybe a flu shot, something very quick. But what CVS Health has done is they've decided, you know what, this concept of let's completely reinvent the front door of healthcare. Let's really put a lot more investment, put more providers, put more resources into our stores, and more focus on chronic care management because, again, they own Aetna, so they have a lot of these folks that are insured. They provide the care, they provide things to their insured population in these stores. Hopefully, the idea then would be by offering this care on a much more accessible basis, avoiding the hospitals, you can bring down the overall cost of care. And that's kind of their strategy. And not sure if anyone's seen any of these right now, but they're going on a systematic rollout of about 1,500 of these new minute clinic on steroids, if you will, these health hub stores going across the nation. And here's some of the listing of some of the services that are being provided. So far, from what we understand, the uptake has been incredible. Consumers have really been happy with the services and the performance they've received. And again, the ability for CVS to do this almost overnight, in 1 year, to roll this out across the country in about 15% of their stores, that's pretty daunting when you think about it from a health system executive perspective. Nothing happens in health systems overnight. Things always take time to kind of go through and planning and strategies. And for this to go on, and if the version goes on that they're expecting, this again, as I mentioned before, is a pretty major issue for them to contend with. So the last trend that we're going to talk about here today is potential disruptors. Oh, okay. Sorry. So again, the consumer survey that we talked about before Kaufman Hall does each year, what we wanted to do was get a sense of not whether people use Amazon, Google, or Apple. Obviously, everyone uses them. But what's from a consumer perspective, is there a level of trust, if you will, with consumers and these three big tech companies? Would consumers really trust Amazon, Apple, or Google to really provide them with, let's say, a mobile application to direct them to this lowest cost of care? And what we found is, at least the key difference here is by age. Between the 18 and 44 segment, about 3/4 of folks said they would trust them, and about half when it's 45 and up. And from our standpoint, that's a pretty critical thing. So when you think about Amazon, 100 million Prime members that are out there, with the saturation that they have in households, I think there's something like in 60% of the households, and of those households, they have a further concentration, those households that have higher incomes, which again are more commercial plans. You can start to stitch together a little bit and say, well, that's a pretty scary prospect when you think about it from Amazon, what they could do in terms of redirecting care potentially. And we expanded this question to ask, including the three big tech companies, we expanded the question then to ask, let's put in the local health system and the insurance company as well. So what would the results then hold there? So the headline results are still consistent. What we found a little surprising, frankly, is insurance companies were up there also in terms of the online tools, that folks would trust them. Typically we never thought that the public opinion was that favorable for insurance companies, but nevertheless they have more trust. And what's interesting, again, for the folks that the clients that we serve most, local hospitals and health systems are on the bottom of this curve right now in terms of that trust level, being able to stand up an online service. So these are some of the pressures that are going on. And finally, with disruptors, this is kind of our standard provocative slide. Let's kind of picture what could happen. So we put these slides out with a lot of the folks that we talk to, and again, it's not out there. This is a complete hypothetical right now, but is it possible, or is Amazon thinking about this right now, rolling out a very low-cost insurance product where perhaps unlimited virtual care could be provided, significant discounts to various providers, low-cost premiums, again, they have over 100 million Prime members, and the brand that they have, and frankly, every one of us uses them every day. So, again, we don't have any special knowledge of when this may change or not, but we tend to think that Amazon is probably one of the major disruptors that could really upend the healthcare market. We show Apple here as well. Their focus has definitely been on the provider side, but what they're really trying to combat here is the ability to access patient records easily. So right now, very difficult to access your own patient records, and even worse so if you're going to different providers. So let's say you go to one health system, you get all your care there. Then suddenly you decide you're on vacation or whatever the case may be, you're caught somewhere else. The ability to access those records at your other healthcare system, virtually impossible right now. That's got to be done completely on a manual basis. It's got to be actually faxed over right now. That's kind of the latest technology that's there. So what's happening is the administration this is another effort where they're trying to force interoperability between all the electronic medical records among the health systems so that patients actually can benefit, and there is this interoperability, and you don't have to change your records over, and you're not kind of contained, if you will, with one health system. Now you have more choice, more freedom. So finally, to kind of wrap this up in terms of the trends, why scale matters in healthcare. So when we say scale, we talked about some of the companies that are out there, CVS Health, United Healthcare. These are both companies that are about $240 billion in revenue, huge amount of resources, not only from a financial point of view, but the internal talent, the scale of these companies here as well. We talked about CVS, 11,000 stores nationwide, and they could make changes very quickly. So from our vantage point, what we talk to our health system clients about is that what we're seeing more and more is you're probably seeing some of the local hospitals in your area. You might have heard a little bit more about the consolidation that's gone on. One health system takes over one hospital versus the other. And traditionally, since I've been at Kaufman Hall, which has been 10 years, when I first started, acquisitions were all about there's a troubled hospital, there's some sort of financial concern, bad management, something went on, then there'll be another hospital system to save the day. And usually the business case for something like that is you save on synergies, you could drive costs down, better contracting, more efficiencies, more back office efficiencies. But really now, a lot of that consolidation has really subsided. Right now, a lot of the health systems are out there, they're trying to think about this a little bit more holistically and say, okay, if we're facing all these different competitive threats right now, what should we be thinking about a little bit differently? And probably the areas that they're most efficient is financial resources. They certainly can cobble together financial resources for what they need. But the areas that are probably, you may not think about all the time, but, I'm sorry. Am I still running? Okay, good. The areas that you may not come to mind initially is two elements. One is trying to capture internal talent, and the other one is the ability to attract innovative partners. So the one thing health systems still have, which is a huge advantage right now, and they're trying to monetize it, and they're thinking of different ways to partner with other companies, is data. So electronic medical records have been in place for about 7 to 8 years to a large degree. Huge amounts of data on patients in terms of all the different episodes of care that have been provided, all the different outcomes, all the different tests, all that information. And what's happening right now is, Google's probably one of your better examples. Right now, they're working with Ascension, large health system in America, and nationwide Catholic health system. They're trying to partner with them so that they can take all this treasure trove of data, if you will, and start creating some predictive analytics. And the predictive analytics to help prevent some of those episodes of care or those bad events happening before they actually can occur with artificial intelligence. So that's really kind of the real gem, if you will, within health systems right now in terms of what they really own. And as they're thinking about different mergers and acquisitions, a lot of that is having this larger laboratory, if you will, between the health systems come together and have this larger treasure trove of data so that potentially that could be harvested for some other opportunities. And then finally, with all the disruption that's going on and the changes that are happening, reimbursements going down, a lot of these other trends that are impacting them, quite frankly, there's just a real benefit being larger from the standpoint of being able to withstand some of these major changes that are happening. So last, in terms of the M&A, just to give you some perspective in terms of how many deals go on a year. So for the last, let's say, 5-7 years, about 100 deals occurred each year. And like I mentioned before, when I first started my career with Kaufman Hall, 2010, largely these deals were small community hospitals, some kind of financial trouble went on, another larger system would take over. Now these deals are starting to become much more sophisticated parties are starting to come together right now. And quite frankly, you're seeing deals that I never thought would occur, which are deals where one health system might be located in Michigan, another health system is located in Ohio, and they decide to come together. Clearly, there's no benefits from the standpoint of contracting or managed care contracting or that kind of consolidation. There's a lot of other strategic reasons that are driving that. And what we're also seeing is that, for those community hospitals that have not been part of the consolidation wave, the next best alternative now for the community hospital, unfortunately, is when M&A is not a solution, then the next step is bankruptcy and liquidation. And we think we're going to see a little bit more of that. Right now, heretofore, it's really been happening more in the rural states, those states that don't have Medicaid expansion. They've really been hit hard, but you're going to start to see some additional community hospitals and some of these other systems go under because, quite frankly, all these forces that are at bay right now are really impacting hospitals and health systems. So with that, now that I've kind of hopefully set the table for folks, I see a lot of yawning and head nodding, so try to perk this up a little bit and not have me drone on. I'm going to love to invite my fellow panelists here and to have a little bit more of a kind of interactive discussion. So maybe to kick it off, Brian.
Yep. All right, great. My name is Brian Clough. I've been in the senior living post-acute care space for about 36 years. I'm currently involved in a few companies. I am an owner and operator with some partners of affordable assisted living facilities in Illinois. We have some senior apartments as well. I'm currently developing 3 new skilled nursing facilities in Illinois. 2 of them are focused on short-term rehab only. The third one has a combination of short-term rehab and long-term custodial and dementia care. I'm involved in an institutional pharmacy business that serves mostly an assisted living population. And the final thing that I'm involved in is probably one of the more exciting things is working together with a insurance company called More Care out of Chicago. That's an IE SNP plan. And working with a provider called Oak Street Health to do enrollment in our assisted living facilities to provide care coordination and primary care. And we'll talk a lot about that today. But it's pretty exciting. We went live January 1st. We've got some interesting results and to date, and we'll talk more about that.
Great. Grace?
Yep, I'm Grace Chen. I've been in healthcare for just around 20 years now, always on the care delivery side. So I've been in academic specialty medicine, dialysis provider, and the last 8 years in value-based primary care. So I'm the Senior Vice President of Care Services for Oak Street Health. My role is to think about programs in serving high-risk patients outside of the 4 walls of our centers. So part of my job is thinking about home-based primary care, think about house calls back in the day, and then working with Brian on this senior living communities and extending our care into that environment.
Thanks. Mark?
Hi, I'm Mark Feinberg, founder and CEO of Stay Smart Care. I've been in healthcare for probably close to 30 years at this point, working for companies like Baxter, Allegiance, and Cardinal. I started a company called Blue Jet Consulting, sold it to Philips in 2015, and then ran their healthcare transformation services business across North America. And then started Stay Smart Care a little more than 2 years ago. We're an in-home monitoring solution that monitors activity, health, and other information to allow people to age in place more successfully.
Great. Well, thank you, everyone. Maybe just to kind of kick it off and warm us up a little bit, Brian, maybe you should start really quickly with, what are some of these trends that are impacting your business or perhaps resonate most with you?
Great. Yeah, and so we had a panelist that was canceled last minute, and Ryan, who's the CEO of New Perspective, so he was nice enough to send me some comments. So I'm going to sort of merge my comments and his comments about the different things. But I think when you look at the 5 healthcare trends that you talked about, the ones that are probably most meaningful to us in senior living really are the healthcare disruptors and changes to access. And I think some of the work that we're doing right now is really directly related to that. And there's been just I've been involved in care coordination or primary care and senior living, post-acute care for a long time, and I've got some real scars and some wounds that I've had to go through. I owned a company. We managed about 1,500 members of Blue Cross Blue Shield that lived in assisted living, and that company failed miserably in the last year, unfortunately. But what you end up seeing is that it's just the lack of quality primary care and care coordination services for seniors that live in custodial care. So the real disruption is really around that. And what Ryan, if he were here today, what he would talk a lot about, and I think everybody in the room could nod their head and agree, from a senior living perspective, we're, as assisted living, even skilled nursing providers, dementia care providers, we're increasingly getting asked to spend more and more time managing the healthcare needs of our residents. There's no reimbursement for it. There's no really knowledge for it. We don't have a lot of quality staff in the building that understand how to manage healthcare services. But every day, more and more vendors are in our building, whether it's the pharmacy, or it's the home health company, or the hospice company, or the therapy company, Part A or Part B, the podiatrist, or anybody else in the building that's in there trying to get more business out of your residents in a fee-for-service model. So I think the opportunity to try to solve for that, Ryan's words are that we're having a hard enough time staffing our buildings, let alone having to staff inefficient time. So how do we get partners to come into our buildings, manage the healthcare, control the sort of healthcare spend issues, get the residents the quality they need, without, while we can stay focused on what we do well, which is really, room and board, hospitality services, and ADL care. That's what we get paid for, Ryan's words, and my words as well. And I think, seeing, again, combining the healthcare access with the disruption is really a great opportunity. And the early results for what we're seeing, it's kind of an interesting conversation Grace and I were having before this. As an operator of these buildings, what we're seeing are just fabulous results. And Grace will talk about what they're seeing as the provider in the buildings, but we're seeing lots of great things happening that really help us increase the efficiency of our staff, increase the quality of services our residents are getting, and just bringing together, getting out of fee-for-service, which does not align well with the healthcare needs that our residents have living in a custodial setting. So, I think that's my answer and Ryan's answer of kind of like the two emerging trends that we see a lot of in senior living is access and delivery, as well as disruption in the space.
So primary care, really aligned primary care coming directly to the senior living facility.
That's right.
Great, thanks. Grace?
The trends that stand out for me are, one, the unsustainable spending is real. Costs are tremendous. There's a lot of waste, I think, that's in the system. And the second is the changes in access and delivery. I think your slides around changes in settings really resonates with me. We look a lot at the inpatient setting and hospitalizations and know there can be a lot of not all of that is necessary, so we should provide the right care for the patients at the right time. That involves coordination. We've got to know the patients. You have to be there as the conditions are changing and direct the care. So we believe in that in value-based medicine. When Brian and I were talking, it was, we had a few admissions last week, and I was bummed out about it because you think those are all avoidable, right? We should be able to avoid the hospitalization, could have gotten a direct admit into a SNF to manage that patient's care instead of putting them in the hospital. And a couple of them are still in there, haven't been able to transfer them out yet. So I think there's a lot of opportunity to quarterback for the patient. They also, I think there's less confusion for them and the caregivers, put them less at risk, and then hopefully take some of the waste out of the system.
Thanks, Grace. Mark?
Yeah, so in the same theme of Brian and Grace, I'm going to go with two options as well. Really the number 4 potentials for disruptors lurking. I see what we do with Stay Smart Care, monitoring technology to support the caregiving that's done in person as a disruptor, but really the need or the demand for that comes from the fact that you have unsustainable spending in our system today. At 18% of GDP and growing, as Andre mentioned, what it does is it just crowds out other investment and it crowds out other opportunity for spending on things that would otherwise be, for a good functioning society. And when you get to a point where you're spending so much on healthcare, that's great for the people who work in healthcare for employment, but as a society, we're not getting, the United States isn't anywhere near the cost curve. When you look at the cost curve of the developed world and their expenditure for value for healthcare, the United States isn't anywhere near the curve. And so from a labor standpoint, when you look at what we're facing in this industry to care for those people who need support services, we just don't have access to the amount of people to do that work. So it's not a luxury to think that we can enhance this and be more efficient in how we drive care for patients by using technology. It is an absolute have to have. So
Great. Thanks, Mark.
So I'm sort of got a dual role here as sort of moderator a little bit with Andre and also panelist. But one of the questions that we have out there is, CVS is expanding the minute clinic model, kind of primary care model, and they're rolling that out, as you pointed out, pretty quickly. Chronic disease management and all of that's going on. I mean, what are the opportunities to focus on primary care, sort of care coordination, emulate maybe the CVS model into senior living, into post-acute care? And Grace, I'm going to tee it up to you for first, but I think talk a little bit about, I know a little bit more about Oak Street than most, and their clinic model. I mean, I begged these guys to get into coming into senior living for 7 years and finally broke through to them. But can you talk a little bit more about the clinic model and how that works and how you believe, that is the right model to bring into senior living and sort of what's happening there?
Yeah, Oak Street is in value-based primary care. So we have centers that are built within communities. Most of our communities are underserved, underrepresented from a healthcare standpoint. The idea is we're there in the community so we can see our patients frequently, get to know them often, and they can come in not just for clinical activities, but also social. Gets us more eyes on them, gets them out and participating within the community and within their care. Our model is also not just the physician and the provider from a clinical standpoint, it's all of the additive services as well. Behavioral health, tremendous amount of behavioral health needs within a chronically ill population. There are social workers to provide some of the psychosocial support. Frequently, the barriers to care are not necessarily the clinical conditions, but transportation issues, which we resolve. Pharmacy confusion, we have pharmacy dispensaries that are located within our centers. It can be lack of caregiver support, so we can direct to homemaker services. So surrounding all of these, in addition to the clinical care around the patient.
So and just jump on that a little bit more. So from the early results of what we're seeing in our senior living communities, with Oak Street coming to the table with the provider, the payer, more care, what we're hearing from our staff, and it's only been 6-7 weeks that we've been doing this, is we're hearing a lot of our staff telling us, I've got 50-60% of my day back. They're getting their day back because what's happening is that Oak Street is in our communities with their resources on their payroll, adding to our ability to do better services in our buildings. It starts with sort of the primary care focus, where what you really recognize, and I did this myself, so I recognize it in my own company that I had before, the lack of really good primary care. Their primary care docs will come into the communities and they'll do the initial history, a new member, and spend 45 minutes to an hour and a half with every member. Some of the doctor that they brought on board was a former doctor that worked in our buildings under a fee-for-service model. And I think his first response was, I've never spent more than 5 minutes with a patient. What do you mean I got to spend 45? So it just shows you how the fee-for-service model just does not align with what we need for our seniors and our communities. And I think in addition to all that, having sort of the gatekeeper or somebody between all those Medicare healthcare billing companies, home health, hospice, care coordinator, whoever else who's trying to come into the building, having an entity be between them and our staff to sort of understand what needs to get done, and then they're very incentivized to make sure the residents are getting the care they need, but not getting the care they don't need, but somebody else wants to bill for. And I think as much as we all want to talk about that, that's a major problem in our communities today with vendors that are coming in and just trying to walk the hallways and get as much volume as they can in our buildings. So I think just that whole opportunity to add, the services, and I want to also say it's really, really hard. You need the commitment of the organization operationally in driving enrollment for the residents in the buildings. It's not easy getting people to switch over to a plan and then to a provider. There's a lot of challenges. You need that alignment to make it work. So, as you look at the CVS question, I think it's a much different age group and population than what you're talking about in senior living.
But in some respects, you think about it, senior living, at least the segue that goes in there, CVS Health, they have a huge Medicare Advantage product, obviously, with Aetna. So are they arguably kind of coming in at the front end, so to speak? So they're going to have the relationship with Medicare Advantage, with Aetna on the front end. CVS Health, perhaps, in the clinic model, can help these folks. And perhaps, on the front end, they're going to really start managing that even before they even enter into the senior living facility.
Yeah, well, and I think that's a great segue. For me, that's exciting because that creates another referral source, right? Because CVS, if they're going to take the risk and actually take full risk in a Medicare Advantage patient or whatever value-based plan they're going to put them in, at some point, they're going to see the value to having that member live in one of our communities where they're going to get better care and services and avoid unnecessary hospitalizations. So, Grace could speak to that as far as one of the major reasons why I think they've made the decision to finally step into senior living, to stick their toe in the water, and how that works within the clinic population.
Yeah, that's exactly right. I think we see it very much as a continuum. When folks move into the senior living communities and move into this program that we've developed, they come out of our centers. So in some ways, we are, taking business away, perhaps. But really, we see it as a continuum. There's a level of need now that the patient has that puts them into a safe environment where we can extend our care. And we have a provider there with our same model, with the same level of support, now in that community with eyes on them to kind of catch them in this next level. We'd love to get to, and I think we'll get there soon, into the skilled nursing facilities. That's the next level from supportive living. So we see it very much as a continuum, as these are chronic conditions. These are patients who are going to get increasingly ill. So we need to have all of these elements in place to grow with them. So I think in the CVS model and the Minute Clinics, they're still going to need support as the patients age. So you need some kind of
to throw out a question
solution.
here, maybe this is something Mark can address. The referrals could come to senior living, but before they come to senior living, maybe they go to an alternative type of resource, whether it be home care or perhaps something else that might be a little bit more cost effective, because again, Aetna, Medicare Advantage, they're worried about cost in that equation, so they're going to look for the lowest cost alternative first before they investigate anything. So maybe Mark.
Yeah, so I think if we're starting to talk about Medicare Advantage products with Aetna and CVS, and their ability to potentially get into, quote, the senior housing industry, personally, I don't really see them getting into that side of things. It's too complicated. Their business is really with a younger population. But that being said, you hit Medicare at 65, and you're not typically seeing 65-year-olds moving into the senior housing product these days. They're typically much older than that. So there's still plenty of runway for them to deal with those types of those patients, those members. And the next logical place for them to really engage with them, unfortunately, isn't in a senior housing product, but it's probably at home with a home care product. And so they're going to be looking for ways to manage that population at home before they move them into the appropriate setting of care. And at some point, it is the appropriate setting of care for sure, for many people. But the initial take on that is probably not in senior housing.
Mark, how long do you think somebody could, using technology like you have or that's out there, how long is somebody actually going to be able to stay at home safely versus making the choice of moving into senior living? Because that's the movement you're seeing happening.
That's a great question. I don't know the answer, truthfully. I mean, I think it's situational for each individual person. But I could see where it would be in the years, certainly, with the appropriate amount of home care. And so at some point, you're simply going to need a set of hands. But technology gets to the point where you need fewer hands in order to deliver that care that's needed. So rather than buying 4 hours of home care and then going to 6 or 8 or 12 or 24/7, maybe you go from 4 plus technology so that at that point you're simulating a 24/7 care in the home, and then you can begin to ramp up from there. I think as Medicare Advantage plans start to take a look at the value that they're starting to acquire in offering supplemental services of in-home non-medical home care, they're going to start to look at that non-medical in-home care as a technology-enhanced version of that, so that they're getting more value for the dollars that they spend for that home care. Plus, they get the data that comes out of it that they can analyze and begin to understand from a health outcome standpoint what's going on with that individual in the home. Because when the doors are shut, they don't really know. And when they buy home care and they deliver that home care in the home, it's just basic EVV visit, electronic visit verification data. We know the caregiver went there. There's maybe some reporting that came out on what was done for that particular individual, but due to the turnover and the scarcity of resources for labor in that market, the quality of what's going on isn't terribly great.
And I think the value of having the data is it opens up the conversation over and over again. So you can see the progression of it, because I don't know the right timing either. I think it's different for each individual. But as you can see the decline or the changes in steps or movement and some of these rhythms that are normally in the home changing, caregivers are then more open to having the conversation of the move. Because that's a very tough conversation to have. A lot of folks aren't comfortable with it, but if you have the data to share with them,
Right.
It makes it a little bit easier.
Well, and I think that's a perfect point, a perfect segue in that you can use this as a tool to really have a meaningful conversation with a family member to say, the data that we're collecting on your family member is suggesting that there is the need to move for additional services or to a higher level of care. And from a risk standpoint, it gives you that information that you can then arm yourself to say, we've made this recommendation based on the following information that we have for your family member to do the following things, and you've refused this. So from that standpoint, you begin to arm yourself as opposed to just not having any of this information and being a little bit in the dark when something happens from a liability standpoint in a community, that this gives you that to arm yourself.
Yeah. What's interesting is maybe another question for you, Grace, is that, one of the slides that Andre talked about was bending the cost curve, right? As a country, we have a problem, right? Rising healthcare costs.
It's not even on the cost curve.
Right, yeah, exactly.
We don't have to bend it. We're not even there.
We've blown it, yeah. So maybe speak to, how the model of care is doing that. Because I think what most of us have all lived through is, managed care where it was controlling costs by denying care.
Yeah.
And the models we're all seeing now, I don't think that's what it's about anymore.
Right. There is a shift in that. It very much is coordinating care. We see that now in the communities that we're serving. There's a lot of services that are being thrown at your residents, our patients, that aren't necessarily needed, nor do the residents necessarily want them. So I think it's important to have someone quarterbacking it to ensure that the services that they do need happen, right? So we make referrals to specialists and ensure that they actually go to the specialist visit and know the plan following. Oftentimes we're discontinuing a lot of services depending on what specialists we use, if they know us well or not. Sometimes specialists who aren't part of the system, aren't necessarily part of value-based care, will then generate 6 or 7 additional referrals. I've seen a lot of sleep studies being referred, not necessarily a need, because what will you do differently with this 87-year-old for a sleep study? So we discontinue some of those services. It takes the patients into environments that they don't need to be. So getting the right services to the right patients, I think, is a big part of this. And advocating for things like, I was just on a call today around compression socks. It's a DME service that's provided, can't get them, can't get it for the patient, and it's working with our payer partner to get the compression socks that will probably keep that patient potentially out of the hospital. So it's coordinating all of that.
Yeah. What's amazing is a senior living company making the decision, like a lot of people in this room either thinking about or started their own insurance companies or thinking about doing it more. But what our organization talked about was, just not what was non-negotiable is the model of care in our communities. How we got that model of care, very open for negotiation and very open for partners. But what we weren't going to do is to try to become the healthcare delivery partner to do that. So I think what, we had a meeting last week in one of our communities with a doctor that had 98% of he's a primary care doc for 98% of the patients in 2 of our communities. And, we had a conversation about making the movement from fee-for-service to value-based. And we talked about all the benefits we've seen to date that come through that. And all he wanted to do was talk about, how he could continue to be the fee-for-service provider in our buildings, and that all these additional services that our residents were getting or receiving, that we should just add more staff to our building so that, they can get those services. Our staffing was too low. And so it's interesting. It's very nice of you that should I increase my costs while you can increase your revenue. And so by the end of the dinner we had, which was nice, I still paid for it, but he sort of understood that it was sort of like this train was on its track, and he either had to get on it or he was going to get hit by the train, because it was really non-negotiable for us. And what really summarized the dinner that really made me feel good about kind of confronting him was he sort of inadvertently made a comment about, a lot of our residents in your building, they have UTIs, and you guys want us to treat your patients in the building who have UTIs. And I said, yeah, we want you to treat them in the most appropriate setting. He said, my reimbursement if I treat them in your building for a visit to treat a UTI or an exam is about $125. If I hospitalize that patient, I get $250. I said, yeah, and then I lose my daily rate. So at the end of the day, it's like you can see where there's just not an alignment of interest with what he wants to do versus what we need. And beyond anything else, what's best for the resident. And the resident doesn't want to go to the hospital. And what we're seeing again early on is an increase of occupancy, not a decrease in cost, but an increase of efficiency of our staff. I'm getting calls from, executive directors saying I have 60% of my day back, or a clinical director that says I have more time in my day. They're managing all this stuff for us. So it's early, but it's interesting results. So I think what we're finding is that the movement to value-based care in senior living for us is sort of non-negotiable. And it's going to be interesting how it happens and finding the right partners. But
So I'm just picturing myself, I'm sitting in the audience right now and saying, okay, I own 4 or 5 facilities. How do I decide to get involved in this, and what's the first step? What might be really helpful to kind of explain to the audience a little bit is, what's the business glue here if that comes together? So I'm a senior housing operator. Do I go out and start hiring primary care doctors and thinking about, replicating this model? Do I go out and become an insurance company here as well to kind of create that alignment? If you could kind of explain that a little bit, some of the circumstances that...
I think that's probably best for Grace to talk about.
Well, maybe you can start with how did you guys start to get involved
we started on this journey a long time ago. In our communities, when we started our company in 1999, we opened our first community in 2000. We started with a care coordination strategy in place. I mean, we had preferred providers for all the services, for primary care, for pharmacy, and we started with kind of a healthcare delivery. I'm a skilled nursing guy who transitioned into senior living. So I approached it maybe the wrong way from the healthcare side, that we had to surround these people with healthcare services. So many people started from the hospitality side, real estate side, and they wanted nothing to do with it. We have a van, we'll take you to a doctor. We have a van, we'll take you to the pharmacy. We have a van, we'll take you anywhere you want to go. And we don't want to touch healthcare. We provide ADL care and food and activities, and we don't want to touch that. And I remember early days, Mark Schulte, I don't know if he's here, is he in the room, is he even at the conference? But I remember when he was at Brookdale, we had conversation about doing therapy at Brookdale, and he's like, we don't do that. Residents could choose any therapy company they want. We don't do. And then suddenly he became the owner of the largest therapy and home health company in time, and it's kind of crazy. But so I think it's where you come from. So in our company, we always did that. But what we realized that even though we did that and we had great sort of preferred providers, we were not getting the results that we wanted. So our journey began a long time ago, and we did a lot of things. I failed at most of them, but this one's working. And I think what we did is found a good payer that got it. We had a bad payer, Blue Cross, who was 85% market share in Illinois, but they still didn't get it. So that failed. And then we found a payer that was really building their benefit plan to meet the needs of this population. And then we found a provider that was willing to come in and take on the direct care role.
Yeah, I think the key for us is ultimately getting to full accountability of quality and cost of care. This was our way to, on a path there with the right partners where it was primed for us in our backyard of Chicago. I think the value-based piece of it is critical. You've got to have folks who are in that same mindset in order to be thoughtfully directing care and out of the volume business that so many of us in healthcare have been a part of.
Yeah, and really, Andre, the key to success and sustainability on this is having this come together because, as a senior living provider, we have a resident that falls in our community, we have to send them out, right? They fell, we have a liability problem, right? If we don't do anything, we're gonna get sued maybe, and we gotta do something. And if we're gonna enter a value-based care, program with a provider, we have to work through those things. So we can't just automatically, be in a defensive position from liability. We've got to work through them and understand how do we get ahead of this? Do we monitor people? We have to have the protection from liability, but it doesn't mean we have to send everybody out. We have to come up with another model, and we have to come up with another way of doing it. And I think, part of it, Mark, to kind of drag him into this fight a little bit, but our discussion is the technology piece is huge. And we're sitting up here talking about, what kind of things can we do to use technology to predict who's going to get sick, because as we move down this path, I want to increase occupancy by decreasing discharges. They want to keep people out of the hospital, otherwise they have to pay that bill. How do we keep ahead of that and gather data and information to sort of understand where to allocate resources to who's going to get sick?
Yeah, I mean, the predictive aspect of this is huge. And as you're able to gather more data in a easier, simpler way, the technology that we're using today, 4 or 5 years ago, other companies, for example, you're probably familiar with the company HealthSense, did not even 1/4 of what we're doing at about $250 a month, which is just an unsustainable. I mean, nobody really could afford it. Today we're doing a heck of a lot more than that for about $80 a month. And so when you think about the predictive element of being able to gather all this data and use it to really understand what might happen in the near future and use that predictive element, I'll just go back to that labor piece. When you just don't have enough people to deliver care, the technology piece is the only way to stay ahead of the curve. The benefit of the technology in a predictive way allows you to then take it to a level that didn't even exist just a few years ago. So in that regard, working with companies like Grace's and getting into senior housing and home care and bringing home care and senior housing together, you end up with a way to bend the cost curve and a way to deliver value care to the residents in a way that they just haven't had the ability to experience in the past.
Thanks, Mark. Maybe just to kind of pivot this a little bit, following on with the CVS Health.
I think it's your mic that fell.
Oh.
Andre, maybe to get back while you're putting your mic on.
Yeah, go ahead, please.
To get back to your original question or your earlier question around how do you get started? To me, it's, we have 3 players in this. We have a payer partner, we have the communities and the locations, and you have a provider. I think if you can connect 2 out of the 3, you can find the 3rd. So it's finding someone else who has the same mindset to partner with, whether it be the payer or the provider, and you can together find a 3rd.
Yeah, you don't have to, and I think, we all, at least I pick up every morning and read all the different publications that come out. You read all about companies starting their own, insurance companies. That's a great decision for some companies that have scale and density and want to do that. That was a really bad decision for us to do that because it's just a different business altogether. Talk about complexities. It's just a different business. To get a good partner, who could do that, that's great. And I think that, we want to stay sort of payer agnostic and really focus on the care delivery model in our communities. So we're excited about, right now we're sort of aligned with more care as the payer. But the future, we see Oak Street, being the provider, the value-based provider, and then maybe they're going to partner with every MA plan in the market. And they're going to be able to convince the MA plans, hey, if you have a member that lives in this building, you let us manage it, we'll take the risk. And so we might end up having, if they have 100 people in our building and they have 30 on 2 or 3 different payers, we don't care as long as they're on that same value-based care delivery. That's our focus. So we want to stay sort of payer agnostic. The other thing too, maybe just to throw in here, all this stuff to me, the disruption and all that stuff, somebody wise told me, if you're doing something for less that somebody else is doing for more, you're gonna be okay. Doesn't mean it's not gonna be easy, but you're gonna be okay. And I think the one thing that I come back to in this industry, we're all of us, whether you're assisted living, dementia care, skilled nursing, short-term skilled nursing, custodial skilled nursing, we're all doing stuff for a lot less than anybody else could do. And there's no way to dissect that and not come back to that answer. It doesn't mean people with money, like I ran into a friend of mine at the airport lounge on Monday, was physician, concierge doc, one of the biggest in the North Shore of Chicago, flying to Florida to pick up his dad, whose caregiver got sick. He had to bring his dad back to Chicago, and he said, your next phone call when I get back to Chicago was calling you and say, what do? I got my dad, he needs something. And I said, you have three choices. One choice is, call a private duty home care company and get 24-hour care. It's going to cost you about $500-600 a day, but they're going to be legal, they're going to have insurance, they're going to have health insurance, they're going to get paid proper wages, they're going to have workman's comp. They're going to be, risk, it will be fine, but it's not going to be cheap. I did that for my father-in-law. It was $550 a day, 24-hour care. You can hire, an illegal citizen who's maybe a nurse in another country, Eastern Europe, Philippines, you could pick it. That's going to cost you $200 to $250 a day cash. They're not insured. They fall on your house. They could sue you. Also, bad things can happen, and you got to find them. And they have days off, and they get sick, and they go on vacation. So you have to have a backup plan. So I don't know what you're going to do. Or you can move them into an assisted living facility. It's going to cost you for a really good one, $250 to $300 a day, and and you got you got somebody keeping track of everything. Imagine those are really your three choices.
I'd love to touch on that a little bit further. So just tying in the concept of the aggregators, if you will, the Amazons, the CVS Healths, the folks that really have all the relationships on the front end, just getting back to that. When you talked about, who are the good ones, who are the good facilities, who are the cheaper facilities, that brings up another concept. So one of the things that Amazon obviously does extremely well is price discovery and transparency is completely out there. So unfortunately, the unfortunate thing is the retailers unfortunately took some of the disruption from that, but from a consumer standpoint, it was a wonderful thing. But to kind of tie all these things back here, if you're a CVS Health and you want to start thinking about, well, should I start referring, if you will, because I do have the Medicare Advantage plan, I do have the relationship, who should I refer to? What does the public really know about what a good senior housing facility is? Does that even exist, except for the fact it's a reputation?
Yeah.
Would the industry as a whole be better served to say, you know what, maybe we should come up with something on a standardized basis, because for anyone on any kind of institutional level to trust, a reputation, or that facility happens to be, nice, or there's good good reviews on the internet, that's not going to be enough. Just kind of curious what your thoughts are.
We struggle with it too as providers. Where do we direct? There's so many out there. One of the benefits of this program has been for our own centers that say, great, you have a provider in these facilities, we're going to direct our patients or give them the option of these communities, because at least we know there's a provider there that we know and trust. But I would love some sort of rating system or information that's not just cost-based. It's also services and quality of care.
Yeah, it's a huge question. I mean, we try to, on the short-term skilled nursing side, trying to educate consumers that they have a choice, and how to make that choice is huge. Because you get into these networks, and then they get a list, and they assume that I got a list. I got 5 facilities in a network. My assumption as a consumer is they're all good because the hospital's giving me this list, so I'm going to pick the ones closest to my house. So we, as a provider who's on that list all the time, want to differentiate ourselves because we believe that we're the better solution, and we have the data to support that with length of stay, lowest cost per Medicare beneficiary, quality satisfaction surveys from the people that that had experienced, and we provide a different experience. How do we educate people? We're dying to know. We have no idea. And then you have, I don't know. I mean, it's a huge question. I don't know if anybody's been, yeah.
If you go into the acute care world and healthcare, the core measures, right? And they started out with 10 and then 30, and I don't even know how many they have now. There are hundreds of them. And the core measures were very controversial when they first came out, and everybody argued that, oh, well, that doesn't necessarily define good care. Over time, they've been widely accepted as really a good benchmark for understanding how we can compare different hospitals and their performance. Things like, if you show up in the emergency department and did you get with a particular condition where you treated a certain way, what was the left without being seen rate at a hospital, their outcomes, a number of different things. So my suggestion would be quite simply you bring a number of industry stakeholders who are part of association boards, and you convene a group of people who study this and come to the conclusion that we can all agree that this is one good measure, or these are 10 good measures that every organization can be measured against and compared against, and then eventually grow that to be a larger number, and then put that out there. Because I think that transparency will ultimately serve the industry well in the long run, for sure.
Yeah.
So I'll ask you the next question. What about price transparency? actually having something where, you know, you brought up the point before that if you do something better than someone else and you do it for half as much, you're bound to be successful.
Yeah. Yeah, I think, you know, I think we sort of have price transparency. I don't think that there's too many people out here that are afraid of posting their prices or having their prices out there. It's just, you know, the competitors that will come in and say, okay, you know, I'm, for senior living, private pay senior living, I'm $6,000 a month. The guy down the street is $9,000. Now, what you don't know is we're going to change that based on care levels once you come in. So everybody's playing those games already or trying to figure out where do they fall on their price. So I think it's like checking into this hotel, right? We checked in, which drives me crazy, and now there's some law going to get passed. But you know, you walk in and it's $300 a day, what you thought it was, and there's a $50 a day resort fee. Like, well, I didn't know about that. You know, it looked like you were the cheapest price online. So I think that's the same challenge we have in other places. But I'm not sure that this is an industry that's afraid of transparency. I've never really.
So do you think it's easy for a consumer to compare one facility to the other, absent kind of going there and actually feeling, touching, you know, just trying to think of that?
On price, I think it's easy. On the quality and what happens, it's very, very difficult. My mom lives in an assisted living facility, you know, and you know, she lived in one. It was run by one company. They were moved out by, you know, the real estate owner, and now it's a very different experience than it was. So I mean, she lived there 4 years. So, you know, you don't have a lot of, you know, you got to vote with your feet almost. I mean, you know, I think, but these things change. And even my own facilities that I own, you know, the right leaders, they're doing great. You know, somebody resigns, the wrong leader, you got a challenge. They all go through their peaks and valleys. Mm-hmm. So I think it's hard to say what it is. Anybody questions?
Questions?
Make one other comment if I can on that care question, because I think your comment was spot on. And I really hadn't thought about it quite that way before. We've always talked about seniors housing and care. And now we're talking about integration or health care delivery and chronic disease management and care coordination in our buildings, whoever's doing it. And what we have is a very elastic use of the word care and a lack of definition of what we mean by care, which then leaves the consumer either assuming we are going to provide something that we're not, and that leads to concerns as well. So I think it's an excellent point. Senior care has to define what care means. Now, obviously, there were original definitions in terms of activities of daily living and the personal care that's involved. But now when we're talking about health care, the word care has a different meaning to it. And I think as a sector, we're going to have to sort of figure out how we talk about that, meaning not just here, but basically with our customer. And ultimately, that's also going to be with social media, that's going to be with state regulators, all those different areas. We're going to have to really figure out what we mean by that and what we're saying. And as you said, who's in that type of care business, meaning having an integrated care delivery platform where we're really monitoring mom's chronic conditions and so on and so forth, versus who's just saying, no, all we do is assistance with the basic activities of daily living, and we don't do anything else. You got to deal with that separately. You know, you do all that coordination, adult daughter, with different doctors, and you collect all the tests, and you know, you figure out and so forth. So I think you've raised a really good point that does face us as we look at this healthcare, senior care collaboration.
Bob, how many organizations do you think define themselves as healthcare from senior living side, not the skilled side? Obviously, that's different. But somebody else want to?
You just asked who also considered from the senior living side a part of healthcare. And I was just raising my hand that I did.
Yeah, you do. Okay, sorry. Yeah, so I think it's hard. I don't think you have many people, you know, I think it's changed over the years, certainly, but I think you still have a lot of organizations that say we're not in the healthcare business, we're in the senior care business. And I think that it's a huge challenge, right?
I wanted to add one comment since I have the microphone, and that is, I think that if we're talking about a freestanding assisted living or memory care, that might make a difference in one thinking whether or not they provide health care. Because if you have a full-level campus and you have skilled nursing on your property with the other levels of care, there's a lot of transitions that can go back and forth. And certainly we want to keep people in their lower level of care for as long as possible, but at least there's a place for them to go if that isn't going to work and they need either post-acute rehab and go back, or outpatient from wherever they are, if those services are already being provided on your campus, or long-term custodial care and skilled.
Right, and what our goal is, you know, to the care delivery model, the healthcare delivery model, that piece that gets paid for by the insurance company or by Medicare, should not change based upon where the resident's going or living for their custodial care needs. And that's the problem with our system, is that, you know, right now, that changes every time we move. That relationship changes even for us, right? I have a concierge doctor, but when he's not my primary care doc if I go to the hospital. And if I had to go to a SNF or an AL building, he's certainly not my primary care doc in that setting either. The unique part of what we're trying to do is put that all together so that the Oak Street, the provider, doesn't change. They might be, you know, somebody living in an individual apartment, going to an Oak Street clinic for their primary care. As they age, maybe they get more services at home. As they age, maybe they go to an assisted building where Oak Street's got their model. And as they go to skilled nursing, Oak Street's going to follow that member throughout that continuum. The setting they're in shouldn't matter. And that's what the goal has got to be. The North Star of what we've got to do is that healthcare delivery piece shouldn't make a difference of what setting you live in. And right now it does.
But what you're describing is, in essence, a model where I operate a senior housing facility where we offer senior care, but the senior care is being offered by Oak Street, right? I think there are a lot of people in the room, and I think to Bob's point is that the industry in general talks about senior care. We offer senior care. And it's a nomenclature issue. Are we senior housing, or are we offering care services? Are we part of a CCRC with a skilled nursing facility where we have care services on campus, or are we a freestanding ILAL or memory care that doesn't offer that and then has where you go buy senior care? I mean, it always amazes me. You talk to people, even in industry, and you mention the words home care, home health, and they screw it up, because they just mess up. There are a lot of people who know the difference between non-medical and medical, but there are as many people who know it don't know what the difference between home care and home health is. And I think as an industry, there really needs to be some work done around what is senior care, what is senior housing, what is health care, who's doing what, what's a swim lane, and explain that to the public, because there's a lot of confusion out there, to Bob's point.
And Mark, to your point, in terms of, I think we had this discussion before, is that if technology is improving and you're able to stay in the home longer and longer, when you kind of extrapolate that out a little bit, then you think about it, the senior care providers, they're not going to be winning customers over on the real estate itself. They're going to be winning on the care component, right? Because they're going to be longer and longer and longer in the home. They're going to be able, from a technology standpoint, you can order the Ubers, and all those types of things are going to get more and more customized just for seniors. So when you really think about the endpoint for senior care, what are you ultimately really selling then?
I think we're out of time, but for us, it's a differentiator. We want people to come to our building and see that we have quality real estate services on the ADL, and we have a great healthcare provider in our building. So, and we have the results, keeping people happy, healthier, longer in our communities, which is our goal.
Thank you, everyone. I think that's it.
Yeah.